Next slide. Next. So let us all have an understanding of housekeeping. Can you go to the previous slide? First, we request all of you to mute your microphone and turn off your video because of the internet interruptions. And we ask you to ask your questions through the chat box, and you can raise your hand. Let us go back to the previous slide on the housekeeping, the previous one. We also want to let you know that this webinar is being recorded, and we have it through our social media, including the YouTube channels. And we are also requesting you to make sure that you fill the feedback form at the end of the webinar so that we can be able to improve more. And what is also very important is that you also get this webinar. Next. Next slide. And we are also requesting you to turn on your camera, when you are engaging. So what are the objectives of this particular webinar? Again, it's about capacity building. It is about capacity building to the practitioners and health staff who are working in the public sector in Tanzania. And this one is part of the Global Fund support based on the supply chain transformations that are ongoing in our country. So through this webinar, we will explore the guidelines for health supply chain roles and responsibilities in Tanzania. As you know, there are multiple actors along the supply chain, and we all need to understand the roles of each other so that we can have smooth operations, but also to ensure efficiency and effectiveness in the chain. And we also go through the quantification methodologies for health commodities, and this is particularly in the public sector. So we have an understanding of the common methodologies, but at the same time, we also go through the bottom-up quantification process that has been adopted in our country. So these are three main sessions. And within them, we also talk about the role of the global health supply chain, who is actually a technical support to the whole process of bottom-up quantification. Next. So this is our 2-hour agenda, almost 2-hour agenda, or 1 hour and a half agenda. And we have a talk from Professor Paul Ovan from Empower School of Health to tell us a bit more about the Empower School, what they are doing, their capacity and the engagement in capacity building in health supply chain. We also get results from baseline assessment, and particularly on quantification. And this one will be presented by Siddharth from Empower School of Health. As you know, you have been filling the capacity needs assessment. So it's always good to get to understand the status that we have. And we also have a presentation from the Minister of Health. That one will be done by Ms. Mese Mpatwa on the roles and responsibilities of the different actors along the health supply chain. And we also have a talk from Nabila, who is from the Global Health Supply Chain Tanzania. Yeah, and she basically talk about their support in bottom-up quantification in the country. Then we have a brief discussion from Professor Andy on the quantification methodologies that have been adopted worldwide. Yeah, what are the common practices? What are the common methodologies? and from Professor Andy is from the Empower School of Health. Then we have our own session on bottom-up quantification, and this is what is very key in this particular webinar, on what exactly is done, how to do it. So we have also an understanding about some of the tools that are used in carrying out the bottom-up quantification in the country. And this one will be facilitated by Godfrey Kingalu and Mr. Msafiri. Both are experts from the Ministry of Health. And then we have the question and answer sessions before we go to the poll, which will provide the feedback, from the webinar that we'll be having today. Then we close for the day. So we are expecting to close around 12:30. Next. Now we have the poll. We are requesting all of you try to fill these questions. These are very basic questions, just to give a basic understanding of who we are. Yeah, quickly just fill these questions. We're requesting everyone to fill the questions. We have 3%, yes, please. Thank you. %. At least we should reach 70% maybe. Yes, 57%. Wow, 60%. $65. 68, we are almost there. Yes, we have almost 7%. So we can end the poll now. Okay. So based on the poll results is that we have 68% of the participants who are male. So majority are male. And in terms of the age group, majority we fall under 30 to 40 years, which is very good. In terms of the competence assessment, there's a slight difference, but 51% indicated that they've completed the competence assessment. So we are requesting those who have not yet completed, please do the needful. In terms of understanding about quantification, majority, they have an average understanding in this particular area. So this is also a very good feedback, which indicates the gap that we have. And we believe through this webinar and the coming e-learning program, we'll be able to strengthen our capacities. Now, in terms of the academic background, majority, they are under the pharmacy and nursing, pharmacy and nursing, these are the majority. So thank you so much. Thank you so much. Let us continue. Now we have a presentation from Empower School of Health, and that one will be facilitated by Professor Paul. Professor Paul Ovan is a founder and director of Empower School of Health, and he has worked closely with the ministers of health, heads of state, and secretaries of health to guide public health strategies. He was the former head of Global Fund's Division of Procurement and Supply Chain, and he has advised widely the WHO, World Bank, UNICEF, Gates Foundation, and several other organizations who are interested in the health sector. Professor Paul, the floor is yours.
Thank you, Gladness. Can you hear me and can you see me okay? Hello, can you hear me okay?
Yes, we can hear you, Prof.
Okay, great. So just before I jump into the introduction about Empower School of Health, first of all, thank you, Gladness. Thank you, everybody. I see the participants keep increasing as well, which is good. I just wanted to say some comments briefly about quantification of public health commodities.
Yes.
First of all, this is both an art and a science. It is really the confluence between logistics and healthcare delivery. While it is conducted upstream, it has impact at the global level and at the last mile. And the data needs to come from the last mile. And when we say public health commodities, we're talking about medicines, diagnostics, devices, vaccines. There are thousands of items and they keep changing. So besides that, it's a piece of cake, and I'm sure you're all really good at this. And many of you are very modest because you said that you're average or less than average, which is about 80%. But in all seriousness, quantification is challenging, and it's because the data is never complete and we are making informed and educated guesses in a scientific manner. And it is fundamental to the PSM process, and it's vital to get right as much as possible. So you'll never be 100%, and the technicians, the managers, and the ministers, and the finance people need to realize that these are best guesses. It's never perfect. And this workshop will support you in your capacity building. And as Gladness said, it's led by the Ministry of Health, GHSC-PSM that have already been supporting you significantly, by Empower, and this is with the support of Global Fund. And we hope that you'll find this training useful. And remember, it's a blended approach. It's a webinar with some face-to-face, but significantly, we follow this by e-learning courses as well, so you have continuous access. And if you ever need understanding, explanations, details, you always have access to us, even after this project is completed. So welcome. And very briefly, I go through Empower. Many of you would have seen this because you were there last time. So next slide, please. Mentoring, learning, coaching, whether it's quantification, leadership, or supply chain or logistics, finding a mentor is really important. And we've been very lucky and fortunate to have His Excellency President Kufuor as one of our mentors. Next. We work with partners. In Tanzania, we have several partners, including the University of Dar, the School of Business, CILT, and others. And we're expanding our partnership to work with each country as well. Next. What makes us unique is we bring in public health expertise, e-learning expertise, and at the same time bring in strong project management and supply chain background as well. And we bring a lot of global experience to share with you guys as well. Next. Just to say that, yeah, this is our global experience, all of it, which we are applying in this particular workshop. You'll hear from Professor Andy, you'll hear from Siddharth, and these are very strong supply chain professionals who worked globally. Next. That's it. Thank you very much for your time and all the best. Back to you, Gladness. Gladness, you wish to unmute, or do we jump straight to Siddharth? Sid, you want to, there you go.
Thank you, Prof. Siddharth, are you there?
Yes, I'm there. Thank you.
Yes, please. We'd like to hear the feedback from the baseline assessment. Thank you.
All right. Thank you, Gladness, and welcome to the webinar on quantification. We have been through the baseline assessment results last time. We had a glance, we had a sneak peek. What we're doing now is we're going to jump a little more deeper into what results we've had for quantification. This is as per what the participants have filled out. I will just reiterate from last time. Next slide, please. Yes, I'll skip my introduction. Next slide, please. Okay, so we've had about nearly 200 people who have filled out the baseline assessment, and these are out of a pool of 450 health staff working in the hospitals and the health facilities from the 26 regions in Tanzania. Last time we showed the demographics in terms of how many people have filled out, what is the age bracket, what is the education, what is the where they come from, what is the work experience, etc. Now what we've done is we zoom in into what results we have for quantification. Okay, so most respondents, as you can see, we have work experience and training in front on the screen, and it is no surprise that a lot of staff who have no experience or little experience working in quantification, because traditionally this has not been the need at a peripheral level, right? There's also little focus that has been given to quantification for the staff at the peripheral level, and you can see that 84% have received pretty much little or no training. Next slide, please. In terms of self-assessment, we can see that another 80% plus have expressed that they have no understanding, and majority 97% have little or no understanding about quantification. And this is also reflected in the technical assessment, where we've asked some technical questions on quantification, and majority of the respondents have had an average score which is between 60 to 80%, and there's a good amount of people who have scored below that. And this is not surprising, because traditionally quantification has not been a required skill set at the peripheral levels in the health facilities, because the quantification has been top down. However, in the recent years, Tanzania has started moving towards bottom up quantification, which is the topic of discussion today. And so therefore there's a need for all of you who are attending this webinar today and your colleagues working in the health facilities and hospitals to learn about quantification, because you will have to estimate the medicines that you require on a daily basis and on a monthly basis and on an annual basis in your facilities. And that holds true for all the health commodities, not just a few of them. Obviously, the COVID-19 pandemic has also highlighted the need for understanding the function much better, because you have to estimate how much kits you need, how much medicines you need, and different types of supplies, medical supplies and equipment. So if being at the facility, there's a great need, and that is reflected in the baseline assessment as well. We saw it in the poll earlier in the slide, earlier in the slides as well, that there's a need for understanding quantification. So with that understanding in our mind, let's jump right into what quantification is and what it means for you, for those of you working in the health facilities. Over to you, Gladness. Thank you.
Thank you very much, Siddharth. So now we have a talk on the roles and responsibilities of the different actors along the supply chain. And it's unfortunate that Messi could not join, but we have Nabila. Nabila, are you there?
I joined Gladness. I'm here. Hello.
Okay. Thank you, Messi. So let's let's go to the first slide on the rows. Yes. Messi.
Yes, I can hear you.
I would like to introduce Messi Mpatua, who is a pharmacist and the head of supply chain management section under the Ministry of Health. She's a pharmacist for more than 20 years, yeah, and she has a wide experience in health system strengthening and supply chain as an expert that is giving technical advice. So she has also demonstrated a history of working in the biotechnology industry and health insurance industry. Her skill set is based mainly on resource mobilization, negotiation, business planning. She has wide analytical skills, team building, and marketing research. She also has a master's in business administration, which has a focus in marketing. Messi, you are warmly welcome. We are happy to have you. Yeah, the floor is yours.
Okay, thank you. Good morning, everyone. Habari zenu. I will use both languages. Yeah, and I will talk on the supply chain roles and responsibilities as a key to supply chain intervention and activities in the country, because as we all know that after this session, you'll be able to understand the roles and responsibility guidelines, which was launched in October to describe various supply chain actors at different levels of management, as well as the importance of roles and responsibilities in supply chain function. Also, we used a specific matrix to assign those roles and responsibilities. We call it RACI, who is responsible, who is accountable for what, who is to need to be consulted, and who needs to be informed in those roles and responsibility of supply chain. Next slide, please, Asha. Yeah, the background comes from the holistic supply chain review, which was conducted in 2017, where that review noted that there is a weak clarity of roles and responsibilities of stakeholders at different levels of supply chain. And so there was a need to specifically put down the roles and responsibility. Also, in the audit done by the Chief Accountant General in 2018, he also called for the ministry to map all key stakeholders and define roles and establish an accountability. And also the Office of OIG Global Fund also noted unclear roles, responsibility, and accountability for various decisions to be made during supply chain intervention. So given that background, it was evident that we need this guideline very much, and that's why we came up with this guideline. Next slide, please. As we know, as Aeli said, that there is a lack of clarity of roles and responsibility, and the implication resulting from lack of supply chain roles and responsibility. It was difficult to conduct performance measurement, to hold accountable, and also we had fragmented implementation of supply chain activities. And there is the need for a supply chain roles and responsibility matrix, which I said we used RACI model that can be used to advise policymakers and health sector desk. For example, during introduction of new laboratory system, diagnostic services at the ministry defined the standards, but the role of procurement lies with the medical stores department. So in order for the medical stores department to do procurement, they need to be informed. So in the RACI matrix, the MSD need to be informed, while the ministry is responsible for providing the guideline and guidance on which machine is required. Next slide, please. As we said that while establishing or writing this guideline, Several documents were consulted to map the guideline, and also some existing government instruments, ministries and function, for example, Medical Stores Department and TMDA were also considered and conducted because they are all key stakeholders for the supply chain. So we have various actors at various levels of supply chain. For example, at the national level, we have the Ministry of Health, the Medical Stores Department, the President Office, Regional Administrative and Local Government Central. Also, we have the development partners and implementing partners. And at sub-national level, we have the RHMTs and CHMTs. Some of them were also consulted during the development of this roles and responsibility guideline. And also at the facility level, we consulted various hospitals, primary health facilities, both the health centers and dispensaries. Next slide, please. Well, as we said that we have several actors at various levels, we have the ministerial department agents like TMDA and MSD, and also under the ministry we have directorates which we work with them closely. The DCS, Directorate for Curative Services, the DPS, Director for Preventive Services, and Pharmaceutical Services, which housing the supply chain. And under the pharmaceutical services, we have different technical working group from the sector-wide approach, where we have the health commodities, that HCHT, that is Health Commodities and Health Technologies Technical Working Group. And also, we have the Supply Chain Oversight Committee. The Supply Chain Oversight Committee monitors day-to-day activity and intervention and advise the Health Commodities and Health Technologies Technical Working Group, which is also responsible for resource mobilization. So that is all under the Ministry of Health Central. Then we go to the Ministry of President Office, Regional Administrative and Local Government. At the Central, we work closely with the Directorate of Health, Social Welfare and Nutrition, where we work very closely since they implement what the policies have been made or have been introduced by the ministry. But we work in collaboration because we all serve the common, we all serve the common citizen. Then under them, they have the regional health management teams and also the council health management teams, the CHMT and the RHMTs. And with the development partners, we have national level development partners, while under the development partners, we have the national level implementing partners. When we say DP, we mean development partners. They are the ones who are, we used to call them donors, and now we have we call them developing partners. So we have the national level IPs, and also at the regional and councils, we have the subnational level IPs. For example, AGPI, they are working directly in the regions, and health facility level, MDH and others, like TPHS, MDH, EGPAF, they work directly with health facility in a specific health facilities to support supply chain intervention. And also, other important key supply chain key players emanates from the dispensary, health center, district hospitals, and all the hospitals, because they are the ones who, from the supply chain, they will serve the end user or the patient. Next slide, please. Well, coming to actors in supply chain, we have the management support function. For example, if we want to do the product selection, quantification, procurement, inventory, and distribution, there are the core management support function there should include the system design and strategy, logistic management, information system, the different tools that we use, performance management, organization capacities and workforce, financing, as well as risk management. And in accomplishing this, we work with different supply chain stakeholders or actors, including the medical stores department, who are doing the procurement. We have the TMDA who will register, so the product selection lies with them. We have different programs, the vertical programs. We have the Farmers Council. We have the development partners where we mobilize resources, the Ministry of Health, where all the guidelines and standard treatment guidelines emanates, and other directors, which I showed earlier, the President Office, Regional Administrative and Local Government. Like now, when you do your quantification from bottom to up, you have to pass through the PORAD before reaching the Ministry of Health for those who are under the PORAD. And also the Ministry of Finance and Planning, because they are the ones who give us the finances. Next slide, please. Well, as I said earlier, that the importance of RORE, we call it RORE, its roles and responsibilities in the health commodity supply chain management includes that all actors will be able to work toward a common objective and align their activity. And also they will achieve a shared set of health commodity supply chain and identify who is responsible, accountable, need to be consulted and informed, as I said, the RACI around the core supply chain functions and support function. It also helps to define roles and responsibilities across supply chain core and support management function. Next slide, please. Okay, here we will see general format of RACI, but we will narrow down to today's presentation where our next speaker will speak in details. So we see this is a business process if one wants to do the quantification. The first step is to extract data from the logistic management information system, be it paper-based or electronic, but at the moment we are using electronic. Then we have the next step, which is assumption building. Then we approve at the national level, vertical programs, resource mobilization, MSD procures, and monitors the supply. That goes when the vertical programs conduct their quantification. But when we do it in hospitals, where we will give the examples in those step 7 to step 10, that in the hospitals, normally they collect data for demand forecast from the ELMIS or other electronic system for specific hospital. We know we have Afya Care, Gotoms, and others. And also, after that, the hospital will validate their consumption data from the ELMIS extraction, collect, conduct, and share demand forecast result to the pharmaceutical services unit through the hospital management team, where the PSU will aggregate hospitals' final forecast. So you will be able to see the whole of the RORE into the ministry website. We have uploaded there the guideline. You can access from there. So for the purpose of time, I will only concentrate from point 7 to point 10. Next slide, please. Yeah, as I said, that was the general format of RACI, and now we go to see under the RACI matrix, who is responsible, who is accountable, who need to be consulted, and who need to be informed. We said that step that hospital collect data for demand forecast for EMS and other electronic system. The responsible there is the hospital medicine therapeutical committee. And who is accountable? It should be the hospital in charge, because the hospital in charge is the chairman for that committee, and the pharmacist will be the secretary. But who need to be consulted? All the hospital departments need to be consulted so that their requirements are collected together and forecasted. And who need to be informed? The hospital management team need to be informed of the process. Likewise, for the next step, when they've collected, they need now to validate the consumption data from the ELMS or other system. And here again, who is responsible? Again, the HMT committee, accountable the same, hospital in charge, need to be consulted, hospital department, need to be informed, will be the hospital management team. Then after they've done the validation, they now need to conduct and share demand forecast result with the pharmaceutical services unit at the ministry, where the responsibility is the HMT, who is accountable should be the hospital in charge, who will duly sign the demand forecasted, and hospital department will be informed, will be consulted. Then this will be channeled to DMO, RMO, and eventually ORAC and pharmaceutical services unit. Likewise, when we do the aggregate of hospital final forecast, hospital medicine therapeutical will do together with the hospital in charge and HMT and hospital management team, including the hospital board. That is, for example, of who needs to be, informed, who needs to be consulted, who is accountable, and who is responsible in the quantification of health commodity, essential health commodities at the hospital level. That is national hospital, specialized hospitals, zonal hospital, and regional referral hospitals. Next, please. Now, what are our takeaway points? First, we always refer to the guideline to identify how my organization or agency is responsible, accountable, or need to be consulted and informed. That is RACI, around the core and support supply chain function. And also you need to consider meeting internally as an organization and use the guideline to define roles and responsibility across supply chain as it relates. And we know that a well-coordinated medicine supply system is crucial in assuring uninterrupted supply of medicine, laboratory reagents, medical devices, and equipment. Well, as we said earlier, that this guideline has about 12 supply chain functions, and you can download it from the website of the Ministry of Health. Thank you for listening.
Thank you very much. Thank you very much, Messi. That was very interesting because actually it seems the guideline is providing the governance structure also. So we really request, each one of you, if you really want to have smooth operations, you really need to access this guideline and understand it. Thank you so much, Messi. Now we have Nabila from the USAID Global Health Supply Chain Program, Technical Assistance to Tanzania. So Nabila is going to talk on the role of the global health supply. Next slide. So Nabila is a senior demand planning advisor from the Global Health Supply Chain Program, which is supported by USAID. And she has more than 10 years of experience in health commodity supply chain. That's quite a wide experience. And particularly in quantification, she has, more than 7 years, doing such activities. So we really have an expert here. So as part of the Global Supply Chain Tanzania program, she provides technical assistance in the quantification of commodities for HIV, malaria, TB, and the essential medicines. She's also part of the Tanzania National Quantification Team, and she's been supporting the country on the ongoing bottom-up quantification process. As we all know, that is part of the system redesign. Nabila, you are warmly welcome. We are happy to have you here so that you can share more about the global health supply chain experiences. Karibu.
Thank you, Gladness. Just a little bit of background about GHSC-TA-TZ, that is Global Health Supply Chain Technical Assistance Tanzania program. This is a USAID-funded program that provides technical assistance support to the government of Tanzania in the area of health supply chain management. Our program covers 4 main objectives. These are providing strategic planning and implementation assistance, improving delivery of health commodities and service sites, broaden stakeholder understanding and engagement of the supply chain system, and in strengthening enabling environments to improve supply chain performance. Next slide, please. Specifically for the bottom-up quantification, GHSC-TA-TZ has supported Tanzania in the following areas. The first was in developing the essential health commodities quantification guideline. The second has been in capacity building at regional and council level on bottom-up quantification process. We've also supported development of e-learning content for bottom-up quantification that will be uploaded on public sector websites. When the bottom-up quantification approach was rolled out, there were changes that had to be made in ELMIS, and these changes were taken on board, and all the right areas were reconfigured in order to support the data requirements that would be needed to support bottom-up quantification that is being implemented at the moment. And lastly, we continue to provide support in the quantification of essential health commodities, which includes monitoring of the forecast accuracies and the supply plans that were developed, as well as the implementation of the process itself as it moves from one tier to another across the different governance structures. Thank you so much.
Thank you so much, Nabila. That was very useful because it really shows that GHSC is a partner in the implementation of bottom-up quantification in the country. So we really appreciate for the support from GHSC. And we believe as we continue with these discussions and developments, then we still need to learn more from your side and get more of the technical support from GHSC. So now we are going to start the actual sessions on quantification. Next slide, please. And we are going to have a basic talk on quantification from Professor Andy from Empower School of Health. Professor Andy is a director of training and capacity building from Empower School of Health. He's a GMS certified global fund procurement and supply chain management consultant with a very wide experience of more than 25 years, of working in major international funding institutions and bilateral donors to undertake high value pharmaceutical procurement. So we have a guru in the area, in this webinar, and we are very happy to have you, Professor Andy. And he has also contributed to the major pharmaceutical procurement and supply chain management publications, including Managing Drug Supply by the Management Science for Health. We all know this book. Yeah, we all know this publication is really guiding the sector in terms of development and its activities. But he has also worked particularly in special programs under HIV, AIDS, TB, and malaria commodities. At Empower, Professor Andy leads the PSM training and capacity building portfolio. So he's the right person as we are coming up with capacity building programs, particularly for our country. Professor Andy?
Okay, many thanks, Gladness. So we go to the next slide, please. Okay. Just very quickly, an overview of quantification. So we set the background well before we start on the detail. The definition of quantification, we make that because many people have confused ideas about what to expect from quantification. And there's this confusion around the terms forecasting and quantification. It used to be the case that WHO defined the two separately. So forecasting was defined as a multi-year estimation. So going forward for 5 years into the future. Whereas quantification was defined as only the quantities and the budget for the next order to be placed. In fact, those two terms have been so abused that they're now interchangeable, and we don't try to differentiate between forecasting and quantification anymore. Key point around this is that, as Professor Paul Olvani said earlier, quantification is an estimation. It can never be perfect because none of us can see into the future that well. We use all the science we can, but we also have to use some element of the arts in order to make estimates of where we're going to be in the future. Next slide, please. The point around the advantages, which are often forgotten, is that investing the time, the money, the effort, the techniques in quantification is absolutely cost-effective and worthwhile. If we under-order, then we're into emergency procurements. Emergency procurements are always far more expensive. If we over-order, we're into wasted stock. So it's important to make the most accurate quantification we can, and that means investing time, effort, money, and planning into the quantification. If we do it correctly, we also reduce the human resources involved in other parts of the process. We reduce the amount required in procurement because we don't have to keep buying emergency orders. It is entirely cost effective. And that is the message. Invest the time and the effort in quantification because it really does save money in the longer term. Next slide, please. And click again, please. Good. Our essential message, the major slogan, no product, no program. We cannot deliver modern medicine without healthcare products. If you want to do the malaria vaccination program, you need malaria vaccine. If you don't have it, you can't do it. In order to have it, we have to be able to estimate the amounts that are realistically needed and when they are needed. That is a major effort because I know what I need today, but our lead time is often 12 to 18 months. I have to estimate what I'm going to need in 12 to 18 months' time. And that's difficult, but not impossible if we follow good quantification techniques. Estimating commodity costs. Again, I know what the cost is today. What is the cost going to be in 12 months' time, particularly when we have currency fluctuations involved in procurement? Next slide, please. We often forget this in the technique of quantification, in the Excel sheets and the computerization and all the formula that we use. We often forget our prime focus is the patient, and we must bring that back to quantification. When we focus on the patient, the cost-benefit effects become exceedingly clear, and the need to undertake quantification to the best accuracy that we can become clear. And that drives our need for accurate data and investing in harvesting and collecting accurate data so that we can make the best quantification, so that we can deliver the best care to the patient. Always, we must remember our focus is the patient perspective, not calculations and numbers and arithmetic. Always focus on the patient needs. Next slide, please. Quantification does not stand on its own. It's part of the whole PSM process. It's part of the whole healthcare process. It is interlinked. And by interlinking and by undertaking it correctly, we get the perspective. Investing in quantification saves time, reduces costs, improves planning, and saves money. It affects all aspects of PSM. One key area is that often we've not been good at measuring our quantification. All countries have been doing quantification for many years. If I ask, what is your percentage accuracy? Very few countries can answer. They've never measured how accurate they are because they're not taking a systems approach to quantification and documenting the assumptions and the results and the accuracy year by year. Next slide, please. There are many variables to consider in quantification. Multiple therapies. Therapies are changing all the time, especially with the massive investments that have been made on new products for HIV, TB, and malaria. 4 years ago, hardly anyone had heard of bedaquiline for TB treatment. I have to forecast how much I need, and that means being aware of therapy changes, being knowledgeable on what's in the pipeline and what's coming, especially for point of care diagnostics. We're all familiar now with rapid diagnostic test kits for malaria and HIV. As they improve, as we shift the malaria focus from control to elimination, different test kits, different items involved, we have to project forward 12 to 18 months of what we're going to need in the future, not just today. And that means having that ability and having a sense of the art of quantification, not just the science. Treatment durations are changing as we try to go to shorter treatment regimens for TB and malaria. As we look at those, all the time they're changing. Different products, different diagnostics, different management. We have to be aware, again, what's in the pipeline, what's coming in the future. I need to order it now. None of us could have foreseen the COVID crisis, but we can prepare for pandemics. We can undertake quantification with strategic stockpiles to be ready when such items, when such conditions as pandemics and epidemics hit. Medicine dosages can vary according to the patient weight. In the past, we've often not been good at taking account of that. It's one of the factors we need to build into quantification. Fortunately, with modern computer systems, we can do that. We can be more accurate and look at specific dosage regimens and our weight range variations in the country. Also seasonal variations. Malaria often occurs in the wet season. We don't have it all year round. So we look at focusing on, again, multiple variations. All of those we have to try and consider. Next slide, please. So other variables are the evolution of science, entirely new products being developed, which we have to try and prepare for. And in particular, being ready to phase out old products as we introduce new products and taking account of that phase time along with our lead time for the new products. The ranges of treatment are changing. Entirely different treatment regimens and profiles coming along. Again, we need to be ready to receive that, and that means having knowledge of what's coming. Scaling up treatments all across the board. MDR-TB would be the classic. How are we going to scale up to meet the demand? COVID, how are we going to scale up to meet the demand of COVID vaccine when it becomes fully available? How are we going to meet that? What quantities could we realistically order? What quantities could we realistically use? All part of quantification. Next slide, please. We've listed here only 3 quantification methods. Of course, there are many more, but these are the perhaps 3 key ones just to focus on for now. The consumption method, how much have you used? And then predicting how much more we're going to use next year or how much less. Consumption method has the ability to be the most accurate. That does not mean it always is the best choice or the most accurate. Only it has the potential to be the most accurate. So in the longer term, we generally try to move towards consumption quantification methodologies. Morbidity method based on the number of patients involved and the treatment profiles for the patients. It's often the method we have to use first when starting a new program. Proxy consumption, when we have no data at all. We've not used this item before. We don't really understand how it will roll out. So we take examples from other countries or regions, and we try and use that model to estimate how much have we used. All of these require considerable skill and experience to apply them well. Just crunching the numbers, just doing the arithmetic is not enough and will never give us an accurate forecast. It needs this combination of computerization and science alongside the arts of estimation. Next slide, please. Okay, that's me finished. Back to you, Gladness.
Gladness, over to you.
Thank you, Professor Andy. That was very useful by setting a very good background. And we will continue with the bottom-up quantification, the one that is going on in Tanzania. That one will be facilitated by Mr. Msafiri and Kingalu. But it's very important for the participants to understand that we're talking about quantification, but at the same time, we are really need to understand the different methodologies, which ones are appropriate, so that we can have really close to accurate estimations. Karibu sana Msafiri, are you there? So we have Mr. Msafiri, who is a pharmacist from the Ministry of Health, and he has been working in this field of pharmacy for more than 12 years now, and he has a postgraduate in procurement and logistics management. So currently, he's one of the facilitators or capacity building experts in bottom-up quantification, in Tanzania. And he has also been working with the ministry under the logistics management section, okay? So he's been supervising and monitoring the supply chain activities and different interventions in the supply chain of medical commodities. You are warmly welcome, Msafiri. Are you there?
Yes, I'm there, madam.
Yes, please. Can you take us through?
Exactly. Thank you, everybody. Good afternoon. Yeah, before we proceed, let me make it clear. Our session concerning the quantification has got two parts. One part will be done by me, Mr. Msafiri, and the rest will be done by Mr. Kingalu. So we are going to take you through those two parts, one being the governance part, and the other will be the session concerning the tools that are used by the facilities in doing the forecast. But before going further to the session, I would like to take you a bit to the history. Where are we coming from and where are we heading, so that we can be in the same boat. Historically, the quantification in Tanzania was done from the top level to the down level, and it was called the top-down approach. But in the recent years, we have been trying to shift the equilibrium from top to down, whereby the facility by themselves will be able to forecast what they want and what they need in order to improve the quality of services they are offering in their facilities. Important is to know that these changes in quantification approach are necessary as per the government laws and acts, which need each facility to submit the annual requirement to MSD before the 31st of January every year. Having said that, then I have to take you through to the rationale of doing quantification in Tanzania by using the approach of top-down. As I've said, the top-down approach has been phased out. Now we have the bottom-up approach, in which the facility need to quantify for themselves. So the rationale of having this bottom-up approach is that we tend to need the data that are very accurate from the facility by themselves, so that we can avoid saying that this is not my data, or this is not my forecast or my demands. In this regard, the new bottom-up approach will be the source of data for demand forecast for essential as commodity, and will streamline the procedures and processes in the demand forecast of essential items. Next. As I've said, the process of quantification is governed through several levels. And in our approach, we have set up the structures that govern each step from the various levels. And we have categorized the levels from primary health facilities up to the national level. But as you can see in the slides, level have been shown there, starting from the primary health facilities, in which we have the dispensaries, health centers, as well as the district hospital. Also, we have the cancer management team as a CHMT. We have the regional health management team. We have the PRAG, as well as the big hospitals. And these big hospitals have been categorized as the specialized hospital, zonal, referral hospital, regional hospital, as well as the Muhimbili National Hospital. But also we have the National Quantification Team, which oversee all the procedures of the quantification. But also we have the Minister of Health as one of the governance structure in quantification. As we can see later, the roles that are played by the Minister of Health, as well as the medical store department. Next slide. So as I've said earlier, each level has the role to play. By starting with the primary health facility, the primary health facility particularly have to extract the data from the ELMIS, and later they will validate those data before they populate into the demand forecasting compilation tool. But in the long run, they will be asked also to adjust the data based on the forecast requirement, as well as the interventions, or if they have any expansion of deficits, they will be asked to adjust their forecast as per needs. Next. The CHMT, being one of the level in quantification, also have the role to play. There are several roles that are to be played, but few have been mentioned here for the sake of you to understand. One is to train the primary health facilities on how to mine the data and pull them into the forecasting tool. The other is to determine the scope of demand forecast, such as to look for the number and type of facility within their councils, as well as to check up for the emergencies, if the demands have met some of the requirements, like emergencies and other interventions. Also, they will have to clean the data from the primary health facilities. Next. Also shall provide or determine a necessary quantities of health commodities described in the scope consumed by each or all facilities in monthly or quarterly basis. If this information is not available, then total quantity supplied to the facility in the target area can be used as a proxy consumption. So they have to make sure all the facilities make their consumption. As you can read, there are a number of functions that are to be played by the CHMT, as well as to incorporate this activity into the CHP. Next. The RHMT have got a role to play also. They have to aggregate all the demands from the councils and submit those demands to PRAG. Also, they have to obtain and keep records of demand reports from the council, and they will perform any other role that have been assigned by the National Quantification Team. Next slide. The PRAG, as I've said, is one of the level that has to be involved, and this PRAG will aggregate the demands from the region and submit to the Minister of Health. Also shall provide guidance and technical support to RHMT, but to keep records and other documents that are from the region, as well as to perform any other role that will be assigned by the national quantification team. Next slide. The other level is the hospitals. As I've said, we have the national hospital, specialized hospital, zonal referral hospital, and the regional referral hospital. All these are needed to extract data from the forecast in the AMS and put them into the respective tool of the hospital tool. But also they have to conduct actual demand as per scope and SOP at the hospital level by considering all the products that are needed, or if the product has been phased out, they have to check that and ensure the requirements are as per stipulated. Also, they have to submit their forecast to PSU at the Ministry of Health through the medical officer in charge, and these hospital can also perform any other duty that would be assigned by the hospital management team as far as the quantification process is concerned. Next. Yeah, the Ministry of Health, as I've said, has a role to play. And as you can see, there are up to 5 roles that are to be played by the ministry. One is to aggregate demand from the hospitals, these giant hospitals, as well as to ensure the resources are available for the quantification process, as well as to approve the national demand forecast and share those forecasts to MSD for preparation of supply plan. Next. Yeah, we also have the national quantification team, which comprises of a number of stakeholders. But the roles to be played by this team is that they shall provide strategic advice to government on quantification of essential commodities. They have to train the RHMT, CHMT, and medicine therapeutic teams. Also, they have to prepare, review, or approve quantification, as well as to review the tools to be used during the quantification process. And also, they will prepare a final national quantification report and submit to permanent secretary before approval to the MSD for supply plan process every year. Next slide. Yeah, we have a number of roles to be played, as you can see in the slides. But importantly is to ensure the process of quantification is doable and work swiftly. Next slide, please. Yeah, MSD also have a role to play in the quantification process. MSD shall liaise with the national quantification team on all matters relating to supply planning development. Also, MSD has to prepare annual procurement plan, and this is done annually. And also, MSD has to monitor procurement process and pipeline. But also, MSD shall liaise with Ministry of Health and PRH on the availability of funds for procurement of essential commodities in order to improve health services delivery. Next. Next slide. Yeah, this will be done by Mr. Kingalu. All over to you, Kingalu, for the rest of the part. Thank you.
Thank you very much, Msafiri. So we now have Mr. Kingalu, who has worked with the ministry for about 7 years as an expert in big data analysis. So karibu sana, Kingalu. Are you there?
And yes, I'm here.
Karibu.
Yeah, Asante and thank you. I am Godfrey Kingalu. I will take you through on forecasting data flow as well as the tools of bottom-up quantification. Next. Yeah, this is a forecasting data flow. So we started last year with the extraction of data with the CHMTs. Then CHMTs send those extracted data to primary facility for validation. This okay, thank you. Yeah, I was waiting for that slide. Okay. Let's start with the forecasting data flow. As we know that we started the bottom-up quantification last year, 2019. We started with the CHMT to extract data from ELMIs or any other data source, then send them to health facility so that they can validate their consumption. The process of validation, it depends on the tools of dispensing register, ledger, and others, so that to make the consumption which was extracted from ELMIS being the realistic for them to use it to forecast it for the next year. This is done on August. Then after validating, early September, they submit those annual forecasting. This will include with funding information to CHMT so that they can aggregate those consumption data of healthy facilities. Early October, CHMTs will consolidate, will share their consolidated data to RHMT. Those RHMT will receive those data from CHMT, which include data from all health facility of a particular council. In the same October, RHMT will review those consolidated data from councils and aggregate them to the RHMT tools. And after compiling to the RHMT tools, they submit them to PRAG for review again. But the data which received from RHMT to PRAG, which include all demand forecast of the healthy facilities, councils, and then we got the data of all facility managed by PRAG. PRAG, after finishing the consolidation early December, they will have to submit those demand forecast of those facilities which are under them to Ministry of Health. While in November, National Hospital, Special Hospital, and Zone Hospital, both of them, they submitted their annual demand forecast to Ministry of Health so that Ministry of Health, especially PSU, they will aggregate data from those national hospitals, then submit them to NQT, which also there is part of people from PSU which are in the QT, combine those data for getting the national demanding. After getting those national demanding forecast, they submitted those documents to Permanent Secretary of the Ministry of Health to get approval. After getting those approval, they submitted to MSD for procurement. That is all about the forecasting data flow. Next. In the bottom-up quantification, we have tools. We have health facility comparison tools, which started this year. The forecasting of this year, we use data from the health facilities, and this is the tools of health facility, which divided in the 4 parts. There is facility information, funding source, and then we have commodities down there. Let's start on the especially on the commodities. We have column L. Column, do you see the tools clearly? Hello?
Yes, it is clear.
Okay. We have column J, which needed to be filled by the facility. Then we have column K, which needed to be filled by the facility after validating with the other tools despite of data from ELMIS. Then we have column L, which have got a demand forecast of the facility. This is the quantity that a facility will request for the next year. Then we have column M, these are the price of MSD and the total cost. There is a formula there which will multiply demand forecast and the price of MSD. Then we got that total cost of particular forecast. Also, we have remarks there. If there is any comment facility needed to share with their administration area, especially council, should put their remarks. So this is the field that the facility will need to fill. Let's see the column J. In the column J, facility will pull data from ELMIS, because ELMIS is the only data which is the only tool that capture consumption data of the facility. So they will pull data from ELMIS, then to link them in this tool by using the lookup. After adding them in the tools, they will come to column K to validate. Then after validating, then they will request what they want. At the end, there is a column here which is called total forecasted value in TZ. Wherever facility add their needs, will populate automatically on the category of pharmaceutical, will be there, medical equipment, and the diagnosis, also dental. Then we got the total demand forecast, cost of the total forecast of the facility. So this is the tool which we are using to forecast for the facility. And this tool is
Godfrey? Godfrey?
Hello?
Yes, please continue.
Okay. I was talking about the category of tools which we have for bottom-up quantification. We have a dispensary forecasting tool, which have just a few health commodity according to their level. Then we have health center tools, then the hospital, council hospital, referral, and the special hospitals. They have got only one tool. And also after that, we have a council aggregation tool and the regional aggregation tool, QRAG, and the minutes of health aggregation tool, and last is national quantification aggregation tool. That's all.
Thank you so much, Godfrey. Now we have the question and answer session. You can raise your hand or type the question. If you need clarifications, please ask. I don't see any questions. Questions? There is one question on, please clarify on column J and K. Can we have Harsha, can we have again the tool? Can we have the tool? The Excel tool? Kingalu?
Yes, I'm here.
Yeah, did
Column
you hear the
J.
question? Yeah, there's a need for clarification on column J and K.
Okay. As I told you that column J, these are the data from the system we have, ELMIS. I extracted it from there, then linked it in this tool by using the VLOOKUP function. Column K is the column for validation. This validation will be done by using other tools, despite of ELMIS. They are using those ledger book or dispensing register, depending on the tools that they have. There is Gotomis, Afya Care. Those are the other tools that they can use it to validate what they was found from ELMIS data.
Okay, thank you so much, Kingalu. There's another question. Dear panelists, I hope we are all on. Dear panelists, Nabila, Msafiri, Professor Andy. There is a question on the challenges that one might face in bottom-up quantification. And this is, beyond the issue of data quality. Like, what could be the challenges? Yes?
The main challenge we are facing now is the quality of data which are reported on the ELMIS. That is the big challenge. So most of the time, most of the facility, after extracting data from ELMIS, there is a lot of outliers which they have to clean up so that to make a quality of data. That's the problem that we're facing. But all in all, they can use other tools so that they can validate it to have realistic consumption.
Yeah, to add up on that, also the knowledge of computer skills to most of the staff. Challenge. Yeah, I'm saying that to add up on the challenge, apart from those said by Kingalu, yeah, we have the gap in computer skills. Most of the healthcare workers that are dealing with the process of quantification from the health facilities are having gap on the computer skills. So it makes us difficult for the process sometimes.
Yeah. Nabila, do you want to add something? Yes.
Yeah, thank you, Gladness, and thank you, Leah, for your question. I agree with Godfrey and Msafiri. Some of the challenges that we have experienced apart from data quality, one was the tool itself has a lot of commodities within it, over 3,000. So last year when it was rolled out, it was a bit overwhelming for some of the health facilities to see all those 3,000 health commodities. So what we did this year is that we tried to customize each tool, as Kingalo had presented, to have each tool for each different type of health facility. The other challenge I think that has been experienced apart from data quality is the commodities within the tool are aligned with the country's standard treatment guideline and National Essential Medicine list, which is also aligned with MSD's catalog of products that they can procure and distribute. It is also aligned with the Ministry of Health's policy that public health facilities should procure generic commodities. So one of the challenges faced is some of the tools that are received during the quantification, facilities would fill them commodity names that are not part of NEMLIT. So that kind of creates a little bit of discrepancy, and that's an area that the team usually has to address and provide feedback on. But those are just some of the challenges. And one of the good things is that throughout the experience, as the national quantification team continued to receive these challenges and feedbacks, they were able to address them accordingly from time to time. So I anticipate it will also be better improved as well. Thank you.
Moderator, can I add something to
yes,
that?
Please. Yes.
Yeah, we also encounter challenges on the using the previous tools. For example, this year we have developed the new tools that are from dispensary up to the national hospital, but you can find some of the quantification that are submitted to us have been populated into the previous year tool. So it's a kind of challenge to us that we need to return their demands so that they can use the updated tool. So there is the issue of using the previous tool while we have already developed a new tool. Thank you.
Thank you so much.
Gladness.
Yes.
Mercy here. Also, challenges on the part of the users. As you know, Excel has a lot of functions that need to be applied. For instance, the VLOOKUP and others. I think that also has become a challenging process to most of the users of the quantification tool. And also, one person, Joanna Nicholas, has raised that quantification tool are specific according to health facilities, but commodities extracted from ELMS are not limited to the level of that health facility. So it makes them having a lot of commodities which are not found at their hospitals or at the dispensary level. We will take up that when we do the review, because as you know, this is our second time we are doing the bottom-up quantification. So we will continue to improve the tools so that they are useful for the specific health facility level. Thank you, Gladys.
Thank you very much, Mercy. That was very interesting, and actually participants are raising very key issues in terms of improving, the tools and the process. So it's very good that you are all here and try to take on board whatever is possible. There is something that is being asked by Arnold. Arnold needs a clarification on outliers in data extracted from the tools. Outliers in data extracted from the tools. Can we hear from experts, please? Kingalu, Godfrey, are you there? Nabila? Professor Andy?
Thank you, Gladys.
Yes.
And Safiri, please feel free to chip in as well. So if I can just broaden the response a bit, on outliers in data extracted from the tools, this falls under the area that Safiri mentioned before about concerns around data quality that are encountered during the quantification. And one of the things that the team had done was to provide another guideline to be able to detect these outliers and to review the forecast. Now, what are some of the examples of outliers that were referred to today? One can be in the consumptions that were forecasted. When a review is being done, as you recall, the bottom-up quantification is done through different tiers. So after the health facilities have done their forecast, and when those forecasts are being reviewed by the council, and when the council forecasts have been reviewed by the region, the outliers that can be detected are some of the numbers that may be off, and these can be quickly identified by looking at the trends in the data that has been provided. It's one of the quick ways to detect the outliers apart from the forecast is also the funding amount. When you compare the funding that has been calculated based on the current forecast, when you compare that with the previous forecast, you'd be able to note some discrepancies. So those were some of the examples about what was meant for the outliers. Thank you.
Thank you so much, Nabila. Yeah, and I thank you, Wakisa. There's a recommendation that the forecast tool to have undisturbed formulas. I think he's trying to say the formulas have to be there because we have limited capacity in terms of Excel expertise and so forth. There is another question, and this one is raised by Margaret. That is, what is the role of health facilities in relation to parallel program supplies quantification, like entities? What is the role, of the health facilities for such commodities under entity? Can someone come up?
Would you please clarify the question?
Okay. The question is, what is the role of health facilities in relation to parallel program supplies quantification like NTD?
Okay.
Maybe when we are thinking about it, we can also respond to Aristasius, who is asking if there will be training and there's more in terms of demand for training. So let me tell you that we'll be having an e-learning program, which will have a very comprehensive module, starting from January, a very comprehensive module, on quantification. So despite the ongoing initiatives by the ministry to train the different practitioners at different levels, we'll have such a program where you have access to the training and you can go through the training by yourself. So yeah, that is something very important for all of us to note. Okay, can we come up again now on the role of the health facilities in relation to parallel program supplies quantification? Experts,
I think Mercy is trying to unmute herself.
Okay. How can we help her now?
Yes. I'm on now. Yeah.
Yes.
In response to Margaret's question, she wanted to know what role of health facility in relation to parallel program supplies quantification like NTDs. We are all aware that after the system redesign and after the holistic supply chain review, all these commodities to the health facilities will be pulled and no longer pushed. So health facility will be requesting those requirements, will be quantifying for those requirements so that they can access the commodities. That is what has been arranged in the redesigned system. And also to respond to a question which was raised by, who is she? Mariam. She wanted to know something like why we have different tools in different health facility levels. The answer is very straight, that all health facility levels have different requirements, have been categorized as in the standard treatment guidelines, that these health facilities will receive this type or will use this type of commodities. So it's very crucial that we separate. If you are a dispensary, you don't have to have one tool which will have commodities from the national hospitals. We have experienced that sometimes you find that the dispensary has ordered a commodity which they are not using. And also another reason is it makes it easy for aggregation. at the district level. If the district level have different, like he understands these are my requirements for health facilities, dispensary, and these are my requirements for health centers. And during aggregation, he will know that the health centers in these years have forecasted this amount. So it's for the purpose of understanding what was forecasted for each type of health facility level. Thank you.
Thank you very much, Messi. And there are still recommendations on that the tool should be automated. Okay, so that is a recommendation to improve. Maybe we have the last question. And this one is being asked by Teresia. She's asking if it is necessary that the forecasted items value match the fund projected. Is it necessary? Professor Andy, are you there?
Yes, I'm always here and available.
Yeah. Can you say something on that?
It's not necessary that it match, it's necessary that it be less than. If you're quantifying more than the budget you have, something has to be cut. And of course, we would normally use ABC and Venn systems to undertake that review. It's not necessary that it match exactly, but there are in every country budget limits, and we cannot exceed the budget limits.
Thank you very much. So we're now closing for the question and answers, and this has been very exciting. So many recommendations for improvement, you know, a lot of learning, you know, from the questions and the clarifications. So we keep on this spirit, and we believe all of us will take on board the e-learning program that is from January. And more details will be communicated to you. So can we also now have the poll before we finish? The poll. We need to get some feedback so that we can see how we can improve as we go along. Please vote the questions. Everyone, please. Everyone. We are 133. Let's try to vote. We need to reach 70%. Give your feedback, please. We need your feedback. Your feedback is very useful. As you have seen, we need more of these capacity building programs. Yeah, we are almost close to 50%, please. Please, we'll appreciate if you fill in the poll. We need your feedback. We are stuck somewhere. This is for everyone. Every participant has to fill in. Yes, please. Thank you. Yeah, thank you. Thank you so much. We are going there. We are almost 55%. Please fill in. Please fill in the poll. Your feedback is very important. More good things are coming, but we really need to improve and get your feedback, please. We expect to have more and more capacity building programs. So your feedback is very key at this point of time. Yes, we are still 57. %? Okay. There'll be more time and practice on using these tools in the coming program, so don't worry. Yeah, 64%. We need more. Can you come in? At least we reach 65%. Thank you. So we end the poll. So based on the feedback in terms of how useful this webinar was, that majority indicated that it was very useful, and that is 92% of those who voted. And in question number 2, if someone would like to learn more about quantification, yes, majority indicated that they would like more training to learn more about quantification, and that was indicated by 98% of those who voted. And also to understand if one have ever taken any e-learning courses from the Ministry of Health. 53% indicated that they've taken a course, so we still have 47%, and that is very useful as the coming program is an e-learning course. Have you taken any courses with Empower School of Health? Majority, that is 80%, they indicated that they've not yet taken any course with Empower, but they are interested. So this is a very good feedback as we move along, partnering with Empower to be able to build our capacity and upgrade our skills in health commodities supply chain. Thank you very much. And this is the end of our webinar today. All the recordings will be shared, but you also get your certificate. Yeah, this certificate is under the collaboration between the Ministry of Health and Global Fund. So you get all the directives in terms of accessing your certificate through the chat room, okay? So we expect all of you to receive your certificate for participation within 24 hours. So with these remarks, we thank all of you. Professor Paul, are you there?
Yes, I am there. Thank you, Gladness. Thank you for facilitating this this very useful webinar. I can see a lot of questions and a lot of answers. I hope the session has been useful for everyone. Thank you, Professor Andy. Thank you, Ms. Mercy. Thank you, Ms. Nabila. Thank you, Mr. Godfrey. Thank you, Mr. Musafiri, for the wonderful session. Thank you, Gladness, for facilitating. All the best.
Thank you, everyone. Thank you to all participants. Yeah, this was very useful. Your questions were very, very constructive, and the feedback is also very constructive. So this was really very nice, and we really need to appreciate you for that. So we're expecting to have our last webinar before we go for Christmas holidays, and it will be communicated to you. And we expect you to see you on that particular webinar. So just a few remarks. Please make sure that you fill in the capacity assessment form. And if you have not yet done that, please take my number. I sent it through the chat box so that we can be able to send to you the link. Yeah, so that you can fill in that very important form, which will give us the feedback to understand the type of people that we take through the coming capacity program. So with those remarks, I thank everyone who participated. Thank you, Msafiri. Thank you, Kingalu. Thank you so much, Nabila. Thank you so much, Professor Andy, Professor Paul. Thank you so much. Yeah, and all the participants. Thank you. Sonia, Harsha, thank you. Siddharth, thank you so much. And this is the end of our webinar.
Thank you. Bye.
Bye to all.